So like, what do you think are the main differences between the MDT view and the traditional orthopedic view, I would say?
I think the thing that really trips people in MDT up, and it's really hard, and it goes against what we typically do, is the clinical prediction rules. Like lumbar manipulation. They got the 5 predictors for that: less than 17, there's less than 16 days, FABQ less than 19, blah, blah, blah. All sorts of things that seem totally unrelated to responding to lumbar manipulation. Plus, not to mention, we don't manipulate until we get to the end of our force progression. And so most times we don't manipulate. So to consider, and again, I don't do this, I haven't changed my practice, but to learn and consider doing a manipulative thrust technique on a patient day 1 who happens to fit these 4 of these 5 criteria is totally foreign. But we have to learn that, yes, there is research to validate that, and that on the exam, they are going to be looking for that if they meet those criteria. So those are things that really, I think people go, so what if their hip internal rotation is 35 degrees on one or more or both hips? I mean, they go, why does that mean they should be manipulated? So those things, the clinical prediction rules seem sort of random to an MDT clinician who goes through a very methodical assessment. They seem like they're pulled out of thin air. And that's what they did, though. Actually, they found people that respond to manipulation. They did a regression analysis and said, these are the 5 criteria they spit out that the people that responded best. And like, okay, those seem random, but we have to learn them. We need to know that those are there and that could be asked on the examination. And so I think that really, that trips people up, having to think about practice rules. Now, there's some practice rules that make a lot of sense. So the exam, the OCS exam, is written for as though each practitioner is a PT are the primary person, the first contact person that patient sees, because we're really working towards that. And I think in the MDT world, we certainly believe that we can be that. But we have fracture rules and things like that. So the diagnostic rules about, okay, this patient, with a high velocity accident comes in with, and they describe paresthesias in their hands, they get x-ray. Okay. The accident was over 62 miles an hour, over 100 kilometers, they get x-ray. So there are this Canadian cervical spine rules for fractures, the Ottawa foot and ankle rules, the Ottawa knee rules for radiographs, I think are very valuable if someone is working in a practice where they are oftentimes the first person that they see. Somebody comes in on crutches after an ankle sprain. Do I need x-rays or not? Okay, let's look and see where they're tender. Let's see with their weight-bearing status. Can they take 2 reciprocal steps on each side? That type of thing. So there's some of the diagnostic rules that I wasn't aware of until we got into the OCS study. And I'm like, oh, okay, these are actually validated. But some of on the treatment side, it's really very difficult and challenging. The other thing is the extremity stuff. And we have to recognize that in terms of research for MDT and the extremities, we're still in our early stages of building blocks. Reliability, intertester reliabilities, intra then intertester reliabilities, et cetera, building that pyramid of evidence. And so we don't show up in the guidelines. MDT doesn't show up in most of the guidelines for the shoulder or the knee or the ankle. It doesn't show up in there because we don't have randomized controlled trials. We've not gotten to the pinnacle. So we have to then look at evidence for other things. I think one of the most frustrating things is MDT fell out of the guidelines completely for the cervical spine. The 2017 revision for the cervical spine, there's nothing in there about MDT. In 2008, in the guidelines, we had C-level evidence, which is slight, minimal efficacy. And because there were no really good studies between then and 2017, fell out completely. So we look at this and we go, they're missing the boat. They're missing out. But we also have to realize the standards, and we need to. So it also helps to point to what research needs to be done. And now we have a research committee that's working on trying to help develop trials to try to match what we would need to do to get in these clinical practice guidelines. So there's that. So there are definitely some things that you go, this doesn't make sense. And that's why it's the OCS for the MDT trained clinician, because there are things that you're going to go, that was a terror, you're going to look at it and you go, and the spine was cleared because range of motion of the cervical spine with overpressure did not recreate the patient's shoulder or arm symptoms. And you're going to go, that's not enough to rule out the cervical spine. We do things differently, but at this point, it's not yet well accepted. So they're just things that you go, they're missing out on the boat. And certainly the extremity derangements are completely missed. They do not yet have the sense of that. They dance around it a little bit. They talk about, for the knee, they talk about the lack of knee extension, and restoring that extension is so important to getting back. They talk about shoulder, and they talk about internal rotation deficits for throwers, and then they talk about rapidly regaining that. And so they're almost there with the rapid reversibility of some of these conditions. We call them derangements, but they're not quite there yet. So there's a frustration level that they don't recognize that, and you're having to answer questions on a test that that are not necessarily matching what you might do in the clinical practice, where you're sorting out spine versus extremity derangements and dysfunctions, articular and contractile, all the time. It's a different thing, because you'll be answering things on that exam knowing what they're looking for that doesn't necessarily match what you might do with that same patient in the clinic. You would continue the examination and look for directional preference. In the extremities, you're not going to see that on the OCS, not yet. Years down the road, yes, it will show up, just as the lumbar spine is on there. But it's so those are some things I think that are a bit of a challenge for an MDT clinician.